Can you see this? Can you see my slides and can you hear me?
Yes.
Yes.
Okay, thank you. Thank you for the invitation, especially to Tashar. I appreciate the opportunity to talk to this STEM Indian audience. It's actually my first time giving a lecture to an Indian audience, so I appreciate this opportunity very much. So what is late antibody mediated rejection? We coined this term while at the University of Wisconsin in 2005 when we published some of the Wisconsin experience in antibody mediated rejection. But as we meant it, we included or defined this term as antibody mediated rejection that occurred between day 90 and 365 days post-transplant. This type of rejection usually presented due to an amnestic antibody response that had been missed since at the time the use of Luminex and single antigen bead assays was rather limited in many of the transplant centers in the country. Right now, antibody-mediated injury of the allograft or late antibody-mediated injury can occur at any time beyond year 1 post-transplant. And as Dr. Gupta discussed before, not only the histology of these rejections are very different depending on the patient and whether the reason behind the development of de novo DSA, which is the major culprit in these very late antibody rejections, is the result of medical non-adherence that can be assigned to the patient or assigned to the physician who changes maintenance immunosuppression at a late time without remembering the immunological risk of these patients. I will quote Dave Danovich by saying that kidney transplants have long memories, and we should keep this in mind. We have the first case. This is a patient that received a living-unrelated kidney transplant for IgA nephropathy, and was in 2011, was originally included in the belatacept trial for conversion at 3 months. The patient presented at the end of 2000 or the beginning of 2019 with 3 months of missing belatacept. Prior to this event, 3 months before, his serum creatinine had been 1.36. And now the serum creatinine is over 2. This is the biopsy we encounter in this patient. We see that there are glomerular damages already, sclerosed glomerular with peritransplant fibrosis, quite an extensive interstitial infiltrate with some peritubular capillaritis that can be seen in this photo of the biopsy, but not significant vascular injury. When we move then to the other view, we see that the patient has substantial glomerulitis, and the C4D staining is a C4D staining diffuse. Okay. The second case is a patient transplanted in 2016 that had been having issues by changing from immediate release tacrolimus to long release tacrolimus, in this case, Envarsus. The patient had been having history of some non-compliance, and this is the biopsy that we see at the moment of transplant when she presents with dysfunction. We see as well that is chronic glomerular injury, there is glomerulitis, there is a severe interstitial infiltrate that if you look closer, you can see is composed primarily of plasma cells, as you can see here. but it is also composed of eosinophils, both bad prognosis in terms of any form of rejection. The case number 3 is the case that we intended to include in late antibody-mediated rejection. This is a patient that was transplanted against a DSA against B58. The antibody was only detectable by single antigen beads with an MFI less than 1,000. Therefore, it was considered to be irrelevant at the time of transplant. The patient is transplanted, put in a DSA positive protocol. She presents 3 months after the transplant with this kind of rejection as the cause of the kidney transplant dysfunction, where you can see there is severe hemorrhagic changes in the interstitium, almost a hallmark of antibody-mediated rejection. In this tangential cut of the artery, you see the presence of leukocytes, lymphocytes in the media, but also in the intima, a form of endothelialitis. And when we look at the vessels, we can see that the patient has thrombotic microangiopathy. There are also some components of plasma cells in this very early form of antibody-mediated rejection. So what is the point of these cases is that late antibody-mediated rejection is a term that has to be better defined. It's a highly polymorphic type of rejection, and I prefer to define this rejection on the basis of histology and decide the treatment on the basis of histology. So what we see here is that the majority of acute antibody-mediated rejection that is classically very responsive to treatment occurs early on, whereas the late antibody-mediated rejections that Dr. Gupta just showed will have a component of chronicity. Antibody-mediated rejection that presents late, even during the first year post-transplant, will not have any impact in graft survival during the first year, but the impact not only in patients' graft survival, but also in patient survival becomes evident at 3 years after the episode of rejection. So what we know right now with late antibody-mediated rejection, even if it occurs early in the first year post-transplant, the outcome may not be seen immediately. We need to wait 3, sometimes 5 years to see the result of the impact on graft and patient survival. And this is typical of developing transplant glomerulopathy as hallmark of chronic active antibody-mediated rejection, which usually ends in the demise of the graft within this period of time, 3 to 5 years. The BAF classification helps us to make diagnosis, but I like this method that Phil Halloran has developed on the basis of combining the light or the histology with the molecular classifiers. And it's important because although you do not have access to molecular classifiers, you do have access to excellent renal pathology in India. And what he classifies, he does these 3 types of subclasses: the PG AMR, in which there is almost exclusively acute microcirculatory inflammation. You will have severe PTCitis and glomerulitis, something similar to what we saw in case number 3. The CG antibody-mediated rejection that has double contours presenting classically with transplant glomerulopathy. and the PGCG, in which there is a level of activity, there is still glomerulitis, there is still PTCitis, but there is also a chronicity in the form of transplant glomerulopathy. The interesting aspect of this subclass or subphenotype of antibody-mediated rejection is that you can predict not only the time at which it usually presents, but also the outcome. The classical acute antibody-mediated rejection occurs, the PGAMR occurs early on, and the median time of presentation is about 2 years. The one that already presents with chronicity can be manifested at any time between 3 to 30 years. And the one that presents with combined active antibody-mediated plus chronicity tends to start within approximately 500 days after transplantation, but continue and eventually is no longer can be calculated in terms of incidence by about 10,000 days after transplantation. So you can choose whatever you want to treat these rejections. There is not a specific protocol that will guarantee the success. So in my particular experience, I treat these patients individually and differently. But as Dr. Gupta mentioned, the essential piece of treating these patients is the control of the T-cell response. And among the T-cell subtypes, the most important subset to control is the memory subset, particularly the CD4 positive T-cells that must be controlled in order to control the rejection. We can, the classical protocol that many centers utilize and has been approved by the FDA for AMR trials is plasma exchange, low dose IVIG, plus minus rituximab. In our program and in the University of Wisconsin and University of Michigan programs, the use of rituximab is rather limited, and I can expand later on in which cases we will or we will not use rituximab. I am pleased to see in Dr. Gupta's paper that his new program confirms some of the factors that we identified as being predictors of response to therapy in late antibody-mediated rejection. First, the ones that we can all determine, serum creatinine and urine protein to creatinine ratio. If you have a patient that presents with less than 3 milligrams per deciliter with AMR, the response to therapy is much better or greater than if the patient presents with a serum creatinine greater than 3, and if the patient presents with a serum creatinine greater than 6, I will just pulse the patient, adjust the maintenance immunosuppression, because trying to control the antibody response is close to impossible. Same thing when the patient presents with nephrotic range proteinuria, mainly because that implies the presence of advanced transplant glomerulopathy. You can also look at your HLA parameters, and although C1q assays and IgG1, IgG3 subclasses are not available to you, you clearly can know the number of mismatches, whether the patient has class 1 and class 2 antibodies, and the breadth and strength of those class 1 and class 2 antibodies, knowing that the pure class 2 antibody responds less than the patients that either have a class 1 antibodies only or combined class 1 and class 2. Pathology is very important, as mentioned before. the IFTA scores. An IFTA score of 1, much better than an IFTA score of 2, and the IFTA score of 3, just for that. The problem is that with light microscopy, the pathologist cannot tell you what it is IFTA and what it is edema. So in my interpretation of the biopsy, I always combine the functional parameter, the HLA parameter, and what the pathologist is telling me about the presence of edema versus IFTA. Response to therapy, if you choose to treat your patient, is also important. You must reduce the immunodominant DSA at least in 50%, and the DSA rebound, which is a situation in which the use of rituximab is recommended, is also a predictor as to whether the patient will be responsive to standard or prolonged therapy. And if the patient is non-adherent, the probability of that patient to respond to treatment is significantly lower, as well as is the rejection presents late after transplant or with de novo or pre-existing antibodies. And what we see here is a study from Matthew Elderly, where he reports the proportion of graft survival in individuals in which the DSA, immunodominant DSA, was reduced in more than 50% versus those in which the DSA was not reduced by using plasma exchange therapies or by using non-plasma exchange therapies, namely in this case, bortezomib, IVIG, plus minus rituximab. This is something you may not have access to, but it is important for the different centers where the C1q DSA is available to compare to the IgG DSA. And what we have seen, and this applies primarily to DQ antibodies as the cause of the immunodominant DSA, is that by using IgG alone, we cannot really appreciate the reduction of the immunodominant DSA. In many cases, like the one shown here, we can see that the patient still has high DQ8 IgG DSA, whereas the patient, the level of C1q DSA has reduced, and this is comparable to the clinical response of the antibody. So not having C1q may not be a problem for you. If you see that the IgG DSA is not declining, but the proteinuria and the serum creatinine are improving, these are markers of response to therapy. In whatever the immunosuppression is, for many years, I have preferred the use of calcineurin inhibitors, and this is information from the CTOT-19, the CTOT-09 protocol in which we participated, in which patients with low immunological risk that were withdrawn from tacrolimus had a higher risk to develop DSA combined mixed T-cell and antibody mediated rejection, what led to the early discontinuation of the trial. The use of tacrolimus as a calcineurin inhibitor, but it can also apply in lesser extent to cyclosporine, is that calcineurin inhibitors have been demonstrated in this study from Alan Kirk many years ago, that these are the only immunosuppressants available to us that inhibit them in a very exquisite manner the proliferation of CD4 positive memory cells that we have established play a very important role in the development of any form of rejection, for that matter. So let's see what happened to our patients. Case number one is the patient that presents after 3 months of not receiving belatacept with a very severe rejection. He presented with a serum creatinine of 3. We decided in this patient, since he also had a BANF1B rejection linked to his antibody process, to treat with ATG, plasma exchange, and IVIG. With this, the serum creatinine decreased from a peak of 3.5 to approximately 2.5 milligrams per deciliter. But then there is an increase in creatinine. At this time, the patient is rebiopsy, and there is still persistence of rejection, although the microcirculatory inflammation had decreased. We restart the patient on belatacept. We do not use tacrolimus in this patient. And this is the period of time in which the patient reaches to one of the best functions in the transplant. During the period, the first year of follow-up, he had several waxing and waning of the serum creatinine with related to GI side effects of the medications. And he has been maintained on monthly low-dose IVIG, belatacept, MMF, and steroids. To date, this patient is not on dialysis, has a serum creatinine that has been stable pretty much over the past year, and is still able to work and be active in his activities of daily living. The functional result is not ideal. The patient does not have proteinuria, and in the follow-up biopsies, we have not detected transplant glomerulopathy, something similar to what Dr. Gupta described. The second patient is the patient with plasma cell-rich rejection that presented with acute transplant dysfunction. In my experience, I choose dexamethasone as my steroid of choice to treat plasma cell with very good response, actually, because plasma cells are exquisite to dexamethasone inhibition of the proteasome, and usually is much more effective than other steroids inducing apoptosis of plasma cells. He also received only 3 doses of ATG. Patient was now stabilized on versus MMF steroids with weekly IVIG for a period of 2 months, and has continued since then with a protocol of tacrolimus, MMF, and steroids with stable kidney function. And currently, her serum creatinine as of this past week is 2.25. Is 2.25. The last patient is the classical lay AMR according to the UW criteria. This patient received what we classically define as the kitchen sink. So she underwent an emergent biopsy with pulsar with steroids, and started Plex and low-dose IVIG. When there was no recovery of kidney function, she started on dialysis, and her urine output started to decline. At that moment, given the documentation of thrombotic microangiopathy, we chose to use an eculizumab protocol that required 3 doses of eculizumab followed by 2 additional doses as an outpatient. We restart the immediate release tacrolimus, mycophenolate, and prednisone. And as of this week, her serum creatinine is 1.7, and she has no proteinuria. Her albumin to creatinine ratio has decreased to normal. So in summary, Until the validity of nude surrogate markers is demonstrated, the kidney biopsy remains the gold standard to determine the choice of treatment and the graft prognosis in the so-called late antibody-mediated rejection. Treatments for late AMR vary according to histology, and when chosen carefully, can rescue the graft and yield good results. This term of late antibody-mediated rejection is loosely defined. The best ways to assess it, again, is through the kidney transplant biopsy, because the histological findings are very polymorphic. The presence of IFTA and V lesions should guide the appropriate therapy. V lesions requiring a more aggressive therapy, and advanced IFTA requiring less aggressive therapy, since recovery of function will be low. Serum creatinine and UPCR are also useful to determine the likelihood of response to treatment in patients presented with late AMR. Thank you very much.